Case Western Reserve University's Institute for the Science of Origins proudly presents the Origins Science Scholars Program. The Institute advances the scientific understanding and application of origins and evolution of human and natural systems. The Origins Science Scholars Lectures are presented with the assistance of Case Western Reserve University's Siegel Lifelong Learning Program, College of Arts and Sciences, and Media Vision. Tonight, it's my pleasure to welcome Dr. Peter Faulhaber, Professor of Radiology at Case Western Reserve University's School of Medicine and Director of the Clinical PET at University Case Medical Center. Dr. Faulhaber has just been leading the initial clinical testing of a new PET detector solution from Philips Healthcare. So please join me in welcoming Dr. Faulhaber.
Thank you, Glenn, for the kind introduction, and I do appreciate the opportunity to speak. And many of my colleagues, thankfully, are not here because they're attending another lecture series. There is one critic in the room who's also a radiologist, so hopefully I'll be careful with what I say. Before I start, I have to do a little bit of know my audience, so I'm going to set the stage. After all, this is Origins, and I'm going to talk about when some of these modalities first began. But before I start, how many of you have had, for example, an MRI? Whoa. And how about a CT scan or CAT scan? Now we get into nuclear medicine, bone scans, cardiac scans, PET scans. Oh, you guys are all experienced. So I'm with my people. This is great, but I do hope you're all feeling better. So I feel something myself. Anyway, so what I'm going to try to talk about is the different ways we image the body, and if you look in the dictionary, you'll find various definitions. So medical imaging is a way of using technology to do 2D or 3D imaging in all sorts of different tissue characteristics without having to use a knife to see inside the body. So basically laparotomies, exploratory surgery, all that is primarily by the wayside, partly because of what we do. So I'm going to talk about general radiology, CT scans, X-rays, get into MRI just a little bit, ultrasound, and then I'm going to focus more on the nuclear imaging part of it, which is what I actually know something about. So radiology, basically, or a radiography, uses radiation, X-rays, to do 2D imaging if it's a simple X-ray, 3D imaging as in a CT scan, and you can manipulate this data from multiple angles, and you're going to hear more about image manipulation next week. So the machine is fairly simple now. You've got an X-ray tube up here, and if anybody's had a chest X-ray, you stand in front of that flat surface and the receptor is there, and then the X-ray device is behind you, and we get an image. Now, this technique is not that old. The X-rays were discovered by William Röntgen in about 1895 during experiments with a cathode ray tube, and he took that beautiful image of his wife's hand, which is not too different from images today. So William Röntgen is here, and there's an artificial element named after him, Röntgenium. Unfortunately, it does not emit X-rays, just alpha particles, and all isotopes are radioactive. So you move from something relatively straightforward to a CT scanner, also using X-rays, but in this case, the X-ray tube rotates around the body in 360 degrees. This is not that old either, 1972 by a British engineer, Geoffrey Hounsfield, and Alan Cormack of Tufts, both awarded Nobel Prizes in 1979. This had a huge impact on the practice of medicine. And as I go through this, almost everybody who developed a technique got a Nobel Prize. I'm standing on the shoulders of giants, as they say. So here we have the first axial image of a CT scan of the brain. The white stuff is the bone. And this pixelated stuff in the middle is the brain, and this defect there is probably a tumor. It took about 5 minutes per individual slice, 5 minutes to process it, so quite a lot of time. And now you can actually see something, right? It looks like a brain. You got the skull, sulci and gyri, water inside the ventricles, white matter structures, gray matter structures, all very crisply defined, and maybe about 0.3 seconds per slice, and that's probably slower than it is now. So very quickly, the device looks like this. One enters this tube, X-ray rotates around you very rapidly and can acquire a volume of your brain. And let's see now, 0.3 times probably like a minute, very quick nowadays. Nuclear magnetic resonance is also not that old, but the technique was first described for chemicals in a test tube. They underwent this resonance phenomenon where they, in a certain type of magnetic field, they'd emit energy, and you could figure out what the chemical was. So that's very cool. And again, Nobel Prize in Physics by Bloch and Purcell. Now, you take NMR, nuclear magnetic resonance, and now we do nuclear magnetic resonance imaging, only most of you don't hear the word nuclear when we do MRI. We got rid of that word because it was too scary. So Raymond Damadian in 1971 built the first machine, and many consider him to be the father of MRI machines, whereas Paul Faulhaber did the first image of a test tube, again, a Nobel Prize with Peter Mansfield in 2003. So again, this is not an old field. Now this is using magnetic fields, which you'll hear more about in a couple weeks, I think, rather than X-rays to get 3D images. So the device is a longer tube, though the newer ones are shorter than that, and it's got a field of magnetism, 1.5 Tesla or 3 Tesla, a lot higher than the magnetic field of the Earth. And it's got these gradient coils which emit energy as well, and coils that transform the magnetic field. So you get signals back from the body from that magnet, which I won't go into in any detail right now. But the first image, rather blurry, this is a cross-section of the chest, believe it or not. So the spine here, and then something there, might be the heart. Nowadays, however, you get a nice crisp image, lots of soft tissue detail, muscles, fat. These are great vessels, and the bone is here in black. There's not a lot of signal from bone. But again, very good soft tissue detail. And the machine looks not too much different from a CT scanner, just longer and deeper and a lot more noisier. Many of you know this already. And they can even play music if you really get it working properly. So moving away from those types of things, we have the ultrasound is a very cool thing too, because it allows you to be portable. And the first paper was published, I think, in 1942. And then Ian Donald of Scotland developed the first practical technology in the 50s. So again, not an old technology. And these machines, as you see, are portable. Here's a transducer, which is a receiver, as well as emitting the ultrasound waves. And you can get an image that the patient can look at. Or here's somebody with a gallbladder. The fluid is dark. Sound goes right through it. It's bouncing back from gallstones. So very portable, very quick. As many of you may have had an ultrasound, it's a pretty cool technique as well. So we're imaging the body, and there's a lot of ways to do it, as I just described, including just holding up a mirror in front of yourself. So what are you really doing? My image receptors are having issues, so periodically I may grab my glasses, but most of the time, what we're seeing is a representation, not the reality. So I'm going to describe a way of representing the body, so you see each of the modalities from the same perspective. So, and give you some orientation and some terminology. So the front view here, we've cut away the front of the skin, and you see basically what we call a front view, or a coronal view is the other term for it. So in this view, you get liver, stomach, intestines. We pretty much know that when we have our liver pain or a stomach ache. Now, if you take a cross section through the liver, you got liver, spleen, air in the stomach, pancreas, muscle, and fat. So the transaxial section we often just call axial section for short. So let's go through an imaging sequence of the body using each of these techniques. So if you just do a straight X-ray, a lot of overlapping structures, and you see the white of the spine, bowel, outline of the hips, and so on. Not a lot of detail. So let's move away to the next step. X-rays again, but this time it's the CT scanner, which has very good spatial resolution, and you remove overlapping structures, and lo and behold, you see the same thing you saw on the regular anatomic specimen. Stomach with fluid in it, liver and spleen, and what else do we have here? We have pancreas, and here we have the portal vein, because the patient's had some X-ray dye introduced into it. Again, very crisp. Now what about an MRI at the same slice? Very different. The tissues have different colors, if it were, of shades of gray perhaps. Spleen, different density now, I should say not density, different signal than the liver, pancreas again, fat, muscle, and so on. So just keep building different characteristics, and as you build more detail, you can create a pretty decent diagnosis. And then there's our anatomic specimen. So in my brain is a representation of what I expect to see with every image in order to make a diagnosis. So you kind of develop this inner library of what things should look like until you do ultrasound, and it's all the way out the window, because now no matter where you move this thing, you're going to get, well, this is the liver, This is colorized portal vein. This little guy trying to be measured there is the common bile duct. So these are a little harder to interpret, but not too bad. Then you get something like this, which is what I'm going to be focusing on as we move forward. So this is what? Well, if you just looked at this, it's a front view and a back view of the abdomen. And you got this triangle thing here, which is possibly the liver. You got the spleen thing here, I think. So I'm going to try to show how we get from that two-dimensional image to an image like this, where I'm superimposing the liver and the spleen on top of anatomy. So we'll go through this, and that's more of the advanced imaging now, is doing what's called image fusion to make things make more sense. And the other thing about nuclear medicine is, well, a lot of images are negative, right? CTs, X-rays, one of my favorite ones there. They are negative. X-rays are negatives, right, of a film. So now let's get into nuclear medicine. Some people like to call it unclear medicine because it's fuzzy, doesn't have high resolution, or new clear medicine, as I like to call it. So that was the older name, the diagnostic use of isotopes, because I never was sure where the activity was. But it really is isotopes. So do you think we need a new name? Because the word nuclear is scary, but we still use the word nuclear medicine. So molecular imaging is the visualization and characterization of molecules within the body which change with different diseases. And it would be kind of unfair to use that name because you can do molecular imaging with MRI, ultrasound, certain ways of using contrast and CT, and even ultrasound. But in general, we can do more with different molecules than most of the other modalities. So we use radioactive isotopes either as themselves, as an ion, or you start getting things that are radioactive, like you add neutrons to something. In this case, it's a very simple hydrogen atom. It's still hydrogen because it all has one proton, but the heavier water, like deuterium or tritium, are radioactive. Can't image with those because their half-lives are a bit long, but basically the radioactive atoms we're using are unstable because they either have too little neutrons or too many. And we use this term half-life to describe them as, this is a short-lived isotope. What that means is that as I use a number, half of it is around in 50, how should I put this again? I can't even describe my own words. A short half-life isotope means one that decays in a short time to 50% of what it was before. So a half-life of 6 hours means it's decayed to 50% from what we started with. So we use these cameras now to detect gamma rays emitted from something I inject into you. CT, MRI machines are outside of you, inject stuff through you, whereas I'm looking at what comes out of you. Again, a young field, Joseph Hamilton in 1937 used tracers, but needed a short-lived isotope. I-131 is actually not that short, 8 days. This stuff, developed by a man named Emilio Segre, he got a Nobel Prize 10 years earlier for developing or identifying the antiproton. Now, the reason I wanted to mention iodine was this patient in 1949 was the first patient ever treated with radioactive iodine-131, the first patient ever to be cured of a disease that would have killed him, which was metastatic thyroid cancer. So this was done in New York, and here's the patient before and after treatment. So once this isotope was developed, and I'm almost out of time, the thing really took off. So we use what I call the nuclear medicine library, where I look through this to find isotopes that work. Like carbon, nitrogen, and oxygen all have isotopes that can be used in the human body. They're also the building blocks of our proteins. So nuclear medicine is blessed with the serendipity of that. So to conclude in a minute or so, and this is probably going to be the most controversial part as well, how much radiation do you get? Well, anything I do is from a month to 4 years. And it's, you get more dose in Denver than you do in Cleveland. PET-CT, for example, has 12 millisieverts, which is a lot more than what you see in the background. Travel on a round trip is going to give you a few millisieverts, medical chest x-ray a little more, and a CT of 10. So what's the risk? This patient's getting radiation therapy. They're given a blast of stuff, but one CT of 10 millisieverts is associated perhaps with one more cancer in 2,000, as opposed to staying alive, which is 1 in 5. So identifying an excess cancer is difficult on the background of what we are already going to go through just by living. On the other hand, there's other data suggesting that medical X-ray levels are beneficial, reduce cancer risk, increase longevity because they stimulate the repair process that our bodies have, which we evolved with. And finally, you have to weigh the risk of not having the exam over the risk of the exam itself. And I am ready for questions, comments, criticisms, finally.
So when you talk about slices, how many slices do you have to take to get out an image?
With certain modalities, you're limited in your slices by the resolution. But say a CT scan, you can do slices as thin as 1 millimeter and do multiple, or even thinner than 1 millimeter. But the more you get, the harder they are to read. So you can go 0.2 millimeter slices on a CT scan. We typically sum them, otherwise you kind of get slice overload. But you get very thin, more with a CT than any other modality.
This is a supply chain question. So if you have something that's got a half-life of 6 hours, who produces it, supplies it to you? How do you keep it and use it?
That one is a question that'll come up again, but that comes from a generator, which has a precursor of molybdenum-99, which has a long half-life. So I can order that and have a month's supply because of molybdenum decays to the technetium. So that's a generator-produced one. Others are from a cyclotron that has to be on site or within 2 half-lives away from you in order to allow for delivery. So a lot of it is produced on site. We have a cyclotron here, one at Cleveland Clinic for the really short-lived ones. But that particular one is a generator-produced one. But it's a very good question. And the supply chain can be difficult because the suppliers of technetium, for example, there's a Chalk River Chalk River in Canada has a reactor. It went out of commission for a while. We were getting our stuff from Poland. Heaven forbid it gets forbidden to come into the country, but in any case, it could be a problem.
I'm one of the consumers who's grateful you do have all these tests. I've benefited, made the choice to do it. Although, 2 questions. One, the CT scan, I think, has gradually become the most controversial in terms of being used somewhat casually. CAT scan, I guess, is a better indication. Would you comment on whether you think patients are adequately cautioned about the risks of CAT scans before they're invited to take them? And then I wasn't clear to me what ground you are trying to break. This is a good context, but I wasn't clear on what your groundbreaking goals are.
The groundbreaking is coming. This is the foundation. But to answer your question about CT, we are more and more aware of it, and there's many programs out there called Image Gently or Image Wisely, especially for pediatrics. But that one controversial issue is the assumptions we've made on how dangerous they are based on what's called a linear threshold technique, where all radiation is bad and it's cumulative. Whereas if you take this threshold approach, you can get away with a fair amount of radiation. After all, we've been evolving in a radioactive field for millions of years, so it's probably not dangerous as people think it is. So that's the controversy. Either I give you the worst case scenario, get the data, but the main thing is don't be radiophobic and not get the scan you should get. The second part of the question is the newer CT devices have reduced dose by as much as a quarter just by better image processing, better speed. So we can use less radiation to get the same image quality as we did, say, 5 years ago. So we're especially careful with pediatrics. The other part of your question is that I think, yes, it's over-ordered because of fear of not getting it right or missing something. But very cautious in its use, but I think the risks are probably overstated.
Is there an ANSI-approved international standards development organization that's creating standards for how much exposure, et cetera, is acceptable?
There is a society. Each society of each modality, like the Society of Radiology has one, the Society of Nuclear Medicine has another, the American College of Radiology has another, and so on. But they all have combined in a group whose combined name escapes me. So each society creates values that they think should be attained. Like in nuclear medicine, we have a list of doses above which we will not go. But there is a society, but I don't remember the name of it. If anybody else does, that'd be great.
Is there any work being done on increasing detector sensitivity that might be able to reduce the radiation required to get a good image?
Yeah, I'm actually going to get to that. I have this handy-dandy prop here to help me discuss that in a little bit. But with CT, for example, the detectors aren't necessarily more sensitive, but we put more of them, like a 16-slice detector gets 16 slices from one beam, where it used to be one slice per image. So just by adding that technique, it's allowed you to reduce the dose considerably, but the detector technology is improving. The processing ability to get the same image quality for the same dose is also improving. So all this is happening simultaneously. So the evolution of this field is very rapid.
Thank you for joining us. You've been watching Dr. Peter Faulhaber discussing a variety of medical imaging technologies. For more information on the Origins Science Scholars Program, please visit the Institute's website at origins.case.edu. In the next part of the talk, Dr. Faulhaber will discuss how nuclear medicine uses radioactive tracers to produce images. Now, back to the talk.
What new ground am I going to break? And if I don't break any new ground, you'll all be unhappy that you came to this lecture, right? So I'm going to start focusing more on nuclear medicine because it is one area which I think is underutilized. And if you just watch a couple of commercials, you'll hear about cancer patients whose cancer has a mutation that allows it to be treated with this specific drug, and why God, I did so much better than I would have otherwise. Problem becomes it's expensive, and you don't know how it's working. So the goal of nuclear medicine is to identify when we can treat them effectively. So the rest of this talk is why bother with nuclear medicine and why bother with certain types of imaging. So let's get back to nuclear medicine. It's kind of like chemistry in action. We use tracers or molecules that have a radioactive label, or we can also use a radioactive ion, and you produce an image of a biological process in the body. So it's very different from what you find out with an X-ray, CT, and so on. And the changes in the biochemistry and physiology can be quite subtle and occur before the negative X-ray. Now, these cameras are very different from what you've seen. This one, you'd be hard-pressed to figure out what the heck it is, but this is a big detector. There's another one underneath the table over here. This is an image receptor, and this is a low-dose CT scan. So this is two cameras in one. It's a nuclear medicine camera and a CT scanner. And I'll talk about this in more detail. Now, inside this thing, well, first of all, I have to have a patient with something in them. If I put a patient on the table, you get nothing without the isotope. So you inject something, it emits a gamma ray, it's collimated, it hits a crystal, which emits light in response to the gamma ray, and that gets picked up by these things that are called photomultiplier tube. In these rather elegant advanced imaging devices are vacuum tubes. Some are very small, but I don't know, I haven't seen a vacuum tube in a household appliance in some time. I remember my parents had a vacuum tube stereo set. This is one area where we're still using vacuum tubes. Mind you, they're very sensitive vacuum tubes, but they are. And we'll get to the replacement of those shortly, and that's an area of improved detector technology. So let's start with the simplest possible thing I can use in nuclear medicine, which is an iodine molecule. It's in a lattice until I put it in water. So there's 37 isotopes of iodine. I-127 is stable. And we use two isotopes in nuclear medicine. I-131 emits a beta particle and a gamma, and can be used therapeutically. And then I-123, 13-hour half-life, gamma emitter, and then decays to technetium-120. To technetium, a little bit of error there. Oh yeah, that's right. Should be tellurium, but anyway. It decays to something more stable. Now, what does it look like? I give you an oral dose of iodine. It goes into your body, and your body eliminates it kind of like table salt through the kidneys, except for the iodine that your thyroid extracts. So a goiter is, here's the right thyroid, left thyroid, multinodular goiter. Not bad. Here's a patient who's had thyroid cancer removed. And if you look at that, you're going to go, well, I suppose he's right. It's a whole body survey, and these guys are not the eyes, those are the submandibular glands. Breast tissue, she was lactating before she got her cancer. Urinary bladder, this is about 7 days after a high dose of 100 millicuries of I-131 to treat any residual cancer cells. So this was the innovation that really allowed our field to take off. The next isotope, which is the most common one, is this stuff, technetium, which is 99 mm for metastable. So it decays by a gamma emission, half-life is 6 hours, to something else, technetium-99, which has a half-life of 211,000 years, and then to ruthenium, not rutherfordium. Anyway, technetium is one of the lightest weight atoms that is radioactive by nature. Every isotope of technetium is radioactive. Technetium-98, mind you, has got a half-life in the millions, so it's kind of stable. And it decays by these 140 keVs, which just happen to interact with the crystals of our cameras, which are made of sodium iodide. If it weren't for iodine, I don't know what I would do. And it's produced from a molybdenum-99 generator, which decays to what's called a daughter in a short time as well. So a bone scan is here, and it's not too hard to figure out. Top of the head, this black area is really high activity, urinary bladder, some of it is excreted. Shoulders look like they hurt, as do the knees. Take an x-ray of that, and this whiter area is where there's more bone stopping the x-ray beam. So this patient has bad degenerative disease in her spine. Now, that's a 2D image. And I talked about the advantages of doing 3D imaging, so I'm going to have to do a little bit of discussion of the instrument without getting everybody too lost. So when you do computed tomography or slices, you get better detail. You get stuff doesn't overlap with other stuff. Now, computed tomography, you heard about already with x-rays going through you. Now I got to talk about emission. So I'm imaging what's emitted from your body. So you got two types. You've got the atoms that emit one photon, or you got atoms that emit a positron. We'll talk about that in a second. So that big camera that you saw, if I'm going to get a 3D image of you, I got to rotate that camera 360 degrees around you. And you're lying there trying not to move, and it takes about 30 minutes. And that's really a bit long, and a lot of patients move, but it gives much better detail. By way of example, here's a 2D bone scan of the pelvis, front view, back view. And because we like to be dyslexic in radiology, if I'm looking at a back view, it's as if I'm looking at you from the back, so your right is on my right. So there's this thing here in the sacrum. And now this is a 3D view of the same area, only now this is a cross section, and I'm looking at it as if the patient's feet are coming out at you. So now, of course, the right is on my left, just to make it interesting. But anyway, this gives me much more detail, this line through the sacrum. So this patient is an older patient with pain, and it's an insufficiency fracture that was not seen on x-ray. So you can get much more detail, and I can be much more certain of my diagnosis by doing this, this 3D imaging, otherwise known as SPECT, for single photon emission tomography. Now, when we design equipment, it has to function based on what the particle emits. So this one, positron emission, you get this positron, there's a positive beta particle or electron, and it hangs out for a very short amount of time and hits a friend, a negative beta particle, and emits these two X-ray beams, I should say gamma rays, at 180 degrees apart, 511 keV, very energetic. So now I'm going, to see these properly, I need detectors on either side at the same time so I can catch those guys at the same time. So you do positron emission tomography, you need a complete ring of detectors, and you pick up what happens when those two things hit the coincidence detectors. You can draw a line between the two detectors, and you know that somewhere along that line that material came, and as you get more and more lines, you actually form an image. It's kind of like cross-hatching on a diagram. So the number of ring systems, or the number of rings, increases our ability to detect things. So this gets to be the most sensitive and the best resolution of what we do. So again, we need a label, and the most commonly used isotope is fluorine-18. Short half-life of 110 minutes, has to be produced nearby, and it decays to oxygen-18. And the most common tracer we use is fluorine-18 2-deoxy-D-glucose, or FDG for short. And this material was invented, or I shouldn't say invented, but labeled in 1982. And it's used to identify tumors or normal tissues that have elevated glucose metabolism. If anybody who's had a PET scan, you know that the tumors use more sugar than normal tissue. Alzheimer's dementia, the brain uses less sugar in that setting, and we can find it. Heart disease, we can detect muscle that was felt to be dead. Now, this is a long slide, and the reason I have this here is because the driver also for why this technology has taken off is Medicare. The first approval for PET, despite the existence of the technology for more than 20 years, was in 1997. It's only in about 2014 that all these things are covered. Colorectal cancer, head and neck cancer, lung cancer, and so on. And my favorite down at the bottom, all other cancers not listed. I'm not sure what they forgot, but there's one that's not covered, which is prostate for initial diagnosis, but pretty much everything except with a few exceptions. So the driver in what we do in healthcare is also what we're paid for, unfortunately, and this is why the insurance system needs to be as robust as it is. So what does the normal FDG PET scan look like? This is again a front view where I've summed up a bunch of slices, and as you might imagine, the busiest thing in the image is this guy, which is your brain, which pretty much only uses glucose. A little bit of heart uptake here, liver is this triangle here, spleen, kidneys, and this is colon, and some urinary bladder. Some of this glucose is excreted as if you're a diabetic. Now, when you get one of these scans, you got to lie quietly for a while, don't eat for 4 hours, and just kind of hang out after injection for an hour before we image. If you don't do that, this patient is a swimmer. Now, she swam the day before and hadn't swam since yesterday, but her body is still in recovery, busily using lots of glucose. So the technique is extremely sensitive to normal tissue, abnormal tissue, and this almost looks like a scan of every muscle in your body. But the next advance is to take the PET scanner and put a CT with it. So this has a CT in front, so that's a CT scanner. Behind it's a PET scanner. So now you have a hybrid PET CT. So now I look at the physiology that you've just seen, and I can merge it with the anatomy and be much more specific about where things are. And that'll be the third part of this talk, as we'll get a little bit more detail about that. So again, why bother with this technique of nuclear medicine? Well, you've been watching television and you've been hearing ads. Drug companies have been very happy in educating us that you really need the right drug for the right patient at the right time. So that's personalized medicine, the right therapy for the right tumor at the right time if you have cancer. Other thing is, of course, these drugs are very expensive. So if I can show you're getting the wrong tumor at the wrong time with a PET scan, then we can stop it and change to something else. So how does imaging come into this? Well, planning, evaluation, assessing the tumor biology, labeling that chemotherapy drug, and imaging it. So what are some of the benefits? I'm going to give an example of radiation therapy. Well, improved accuracy of staging and restaging with PET, very well documented, appropriate selection of expensive treatment options, and then knowing if it's working sooner than if you waited for it to shrink and change size. So if you look at radiation therapy, we are, at our institution and most others, we combine a PET scan and a CT scan, and they map the radiotherapy plan based on the combination. So what you want to do is you want to spare the normal tissue. You want to treat the disease, because if it's not treated, it won't respond, and if it's not spared, it won't recover. So anyway, so that's really important. So the final plan is, for example, here's a left lung lesion. This is the PET scan superimposed on the CT. The bright area means it's the most radioactive, and then this yellow line is what's called the gross tumor volume. How much tumor do I think you have? But what they didn't see was this little lymph node down here. So the therapy plan completely changed by adding a lymph node. So if you had a therapy based just on the CT, you would have missed that lymph node and you would have responded to therapy initially and regressed quickly. So the other questions we want to answer are, how long do we wait? How many cycles of chemotherapy do you need? Do you need 4? Do you need 6? And if you're a kid, that's very important. How do you measure change? Size? How about size and metabolism? And what about new PET agents? Well, there are a few out there. Problem is, they're not approved. So prostate has a recent approval, which I'll go into shortly. DNA synthesis would be a great marker. Measuring tumors' low oxygen content would be a great thing to do. Hormone receptors for breast cancer would be great. All this is done in Europe more often than here, but these are coming, and I think the approval process will not be too far behind. So at this point, we can take a break, and hopefully I've answered a few questions with the second part and maybe more so with the third part. So
I've been reading somewhere, maybe Scientific American, where I don't know if that's a good magazine or not, but that certain groups are trying to write software code that's self-learning for scanning, for interpreting the scans, and to enable maybe down the road, 10 or 20 years from now, to help the radiologist either recommend something or do it on a faster basis. Can you comment on that? I guess it's artificial intelligence, basically.
There's a lot of that going on. Computer-aided software, breast cancer imaging, they use a lot of that. Call it CAD for short, computer-aided diagnosis. And there's someone who, I can't remember what company said, basically radiologists will be no more in 10 years because you won't need them anymore because we'll have artificial intelligence. I think that might be taking a little bit too far, but I think having computer-aided diagnosis, I think, will be critical, and it will allow us to be faster. And people have tried it with chest x-rays now. People have tried it with CAT scans. Very hard to do with the nuclear medicine part simply because of the variation in isotopes. But I definitely think computer-aided diagnosis is already here in some circumstances and is coming. But I'm not sure if we'll have self-driven radiologists yet, but it's coming.
Two questions. One, there was some conflict about women and mammographies in 1 year and 2 years, and suggesting not as much, I don't know, radiation or mammography exams.
Yeah, there was a lot of confusion about that. There was our FDA versus some of the European recommendations were at odds with one another. Should you do mammography before age 40? One group said yes, one group said no. Should you even bother doing self-examination? One group said yes, one group said no. So I think there's a lot of confusion. I think we're still tending to follow the older guidelines of starting mammography after age 40, every 2 years, a diagnostic mammogram. In fact, I can't remember the regulations myself because they keep changing. The final controversy is, should an older person over age 80 even bother with a mammogram? Probably not. But the doses of the mammography are coming down, and there's a new type of mammography called tomosynthesis, which actually takes slices through the breast. So instead of just these 2D views, we're getting much more detail. So I think you'll see the recommendations change based on, well, how much better are we getting for tomosynthesis, and are we overcalling it? So I don't even remember them myself because they keep changing. But the tomosynthesis technique, I think, will revolutionize how we do things in mammography. It already is.
For over 30 years, I worked on, I traveled the globe working on international standards organizations like ISO. And listening to you, what I'm seeing is a tremendous need for a standardized international database where everybody on this planet's doing research. It should be coordinated. You need standard terms, standard tests, standard yada, 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 standardized results. And I don't know, I just see a tremendous need for that from the field I worked in for 30 years.
Yeah, that's a huge issue. In fact, there's a quotation I read recently that FDG, the label glucose, will not become as powerful as it can be without standardization. Because right now, I can go to 3 different equipment vendors, get 3 different images, 3 different measurements, and so the standardization is a huge thing that we're working on. Standardizing how is the image reconstructed. Even though the vendors are using different instruments, they're not that different. So that's a huge interest. And there's a committee, as you can tell, I never remember anything when I'm up here in particular. I think the brain goes someplace else, but there are a number of trials, standards working specifically on that. So that is coming, and that's a huge issue. Because you're right, how can I give recommendations if somebody with a different camera gives something completely different? Can't do it. But that's a huge issue.
We hope you've been enjoying the Origin Science Scholars Program with Dr. Peter Faulhaber. Dr. Faulhaber's research interest is in positron emission tomography, or PET imaging. In the second part of our talk, we learned about nuclear medicine and how different radioactive tracers are used to probe different tissues. In our final segment, Dr. Faulhaber will talk about the role of medical imaging in personalized medicine. Now, back to our talk.
We'll start with the next part, which, well, I get to predict the future, and I'm going to be wrong. So with therapy assessment, I think that's where we have to head. We have to get new radiopharmaceuticals. The approval process has to be sped up and so on, but that's not my field. So we talked about personalized medicine. and you're all seeing commercials. I started paying more attention to commercials over the last couple weeks when I was thinking of talking to you, because I kind of wanted a sense of, well, am I going to be over your head or underneath your head, as it were? So the question is, as we do personalized medicine and you get a treatment, you want something that's going to you want the same drug to diagnose your tumor and maybe the same drug to treat your tumor. So is there a therapy tracer in one, kind of like 2 sticks of gum or something? Well, yes, there is. And there's even a magazine or a term for it now called Theranostics, combining therapy and diagnosis with one name. So I would have wanted the diagnosis in front. And yes, there is a journal, otherwise known as Theranostics. So this journal is even over my head in certain places when it gets into molecular detail. But the point is, in vivo, meaning in a person or an animal, molecular imaging, molecular therapeutics, image-guided therapy, and personalized medicine are this magazine's interest. And the more we do, the more I see that this really will move forward. Well, actually, we have a theranostic agent. Remember iodine? Well, iodine happens to have a pure gamma emitter, I-123, which will not injure your cells, small dose, and it's the first agent recognized as potential. The first potential was recognized very early. So once you do one of these, here's a thyroid scan, left lobe, right lobe. I'm looking at the patient from the front, and this defect is possibly a cancer. So something that doesn't metabolize iodine looks cold on one of these scans. Alternatively, this round guy up here is a nodule that's not malignant because it uses iodine. And there's also different other molecules that we can label with iodine as well. So then we get into therapeutic sodium iodide, where we change to I-131. This is an image of the whole body. And like that patient I showed you earlier, should be virtually nothing. So this patient is unfortunately riddled with metastases, but I just gave the patient I-131, and that beta particle will destroy tissue. So it's a diagnosis and therapy in one. So this is the prototypical agent. Diagnose it, change the tag, image it, and treat it. So back to our friend here. This seems to us now to be, what's the big deal? But basically, this was a lethal disease. You could do radiation therapy externally, but you had to hit the patient in multiple locations. And if it was widespread disease, what do? You destroy the bone marrow. So this caused our field to take off. And for a while, it was endocrine-based. For a while, we did brain imaging before CT and so on. So let's look at how can I use my technology to identify disease more accurately. So here's a patient after a high-dose therapy. Remember, the head's up here, something there, the feet are down here. And I know, but this is the cervical spine. I think things got a little shifted in here, up extra arrow. The patient has some gray stuff here, lung metastases, and then this thing down here, I have no idea what it is. Hence the I suppose it's something. However, let's talk about what if I then fuse this fuzzy X-ray, or should say fuzzy axial image. There's the iodine uptake in the axial plane. Here's the CT done on the same session. And then if you fuse it, I now know that that lesion is in his sacrum. And if you look here, there's bone here and there's no bone here. So it's destroying the bone. So by taking this 2D image, creating a 3D image, and having a CT contemporaneously, I can then say where that disease is, and if he needs radiation therapy, we can plan it a little bit better. So this fusion is coming and getting much bigger for what we do. So why bother fusing? Well, the sum is greater than the components. If I do physiology, I'm going to see a limited number of organs, or only one. And I won't know where it is unless I have a reference from an anatomic study done at the same time or contemporaneously. And you can do these with software or hardware. So almost everything we report now has a contemporaneous CT, MRI, ultrasound, X-ray, and we combine our interpretation of the physiology with what's going on in the anatomy. So this thing, we used to do just with our eyes. Here's the X-ray, here's this. Now we merge them with software. So this is where it's starting to get interesting. This is a relatively recent article on a fair number of patients with prostate cancer after therapy. In other words, the prostate's been taken out, but their PSAs are creeping up. So I talked about the need for new tracers, and this tracer got approved for use by the FDA, then approved for reimbursement recently. It goes by the name of gallium-68 labeled PSMA. So gallium-68 is a positron emitter. And it happens to have a 68-minute half-life. Great for testing. And it comes from a gallium-68 germanium generator. I should say a germanium gallium generator. So I order one of these and I put it in my lab and it hangs out for a month and I can label things. So unlike the FDG PET scan you saw, here's salivary glands. This guy is the pancreas, kidneys, liver, spleen, urinary bladder, and something that does not belong. So prior to this scan, we didn't know where this patient's disease was. And if I'm telling you and you're my referring physician, I'm showing you this image, and you're going to go, you really sure you know where that is? Why, yes, I do, because I did it with a CT scanner. And then you fuse it, and you can say, there's the lymph node. You can biopsy it, prove it, radiation therapy to it, or whatever. So basically, this new radiopharmaceutical, we're starting to get a lot of patients. It goes by the unfortunate name of Axumen for reasons that remain obscure. I have no idea where they come up with that name. But anyway, so what about the theranostic approach? So here we have a tracer. It's very sensitive for something that's less than a centimeter. You wouldn't even call that, if you saw it at all on the CT, as being suspicious. So here's a recent study from the Journal of Nuclear Medicine, as well as OncoTarget. Anyway, so now I take the same agent, PMSA, which had a gallium-68, which was a positron emitter, not going to hurt your tissue. What if I change it to lutetium-177? That's a beta emitter, and those particles will travel 1 to 3 millimeters, deposit all their energy, and not hurt the surrounding tissue. So you saw that last patient where there was lots of stuff. You shouldn't see any bone. So this is a gallium scan to show that this poor patient with this really high PSA, you really don't want it to be higher than 4, assuming you still have a prostate. And when you don't have a prostate, anything's bad. So he was treated with this relatively high level of gigabecquerels of lutetium. And this is the next scan after that with the gallium-68. Treated again, and this is the next scan. So we went from a patient who's dying of cancer, much like that iodine metastatic disease patient, to basically relatively stable disease, which a PSA of 27 gone down from 1100. This is what we hope to achieve in multiple other cases. So there's a lot of things out there that have a PET tracer and a beta particle, or an alpha particle, which is even more nasty and energetic. So the thing we're encountering is that the imaging agents and the imaging devices are somewhat symbiotic, which is why I spent so much time on the device. We want to improve over that. But nobody's going to improve it if there's no reason to. You have to have a reason to. So new agents may arise that have the right imaging device. Maybe advances in PET-CT, like digital PET, will have an impact. So this doesn't fit in my pocket very well, but this does. This is the next generation of a digital detector. It's a silicone-based detector, and this basically can replace this and allow you to do a little bit higher resolution PET. So that's one example of an innovation. So we need more PETs. Unfortunately, in this slide, the Chicago Terrier, I think, is going extinct. Cubs won. Anyway, so we are going to try to develop more PET scanners in various ways. So here's a digital PET we finished evaluating last year, image of the brain, 1 millimeter voxel reconstructions. A voxel is a volume of a 1 millimeter per side square. And if you look at this view in the axial plane, it looks a little fuzzy. Same patient, 20 minutes later, and the brain is much more crisp on the digital device. You can see it here too. You can even see his intraocular eye muscles here a lot better than you could here. So this is the next generation of devices that we're hoping to move forward with. So if you have something that can do that level of resolution, then you might be able to see something smaller or even sooner. Alternatively, combining PET with an MRI is another possibility. So how would you do that? You have a washer-dryer system like PET-CT. And in this case, however, there's a heck of a separation. So the MRI is over here. There's 3 meters between the PET and the MRI because the magnetic field of the PET screws up the photomultiplier tubes, and this thing screws up the magnetic field of the MRI. There are newer devices where the PET technology is inside the MRI because you use these things instead of these things. Mind you, they're much smaller in a PET scanner, but they're still vacuum tubes. And this is what the device looks like over in Seidman Cancer Center. So this then allows you to say, sometimes I don't see as much on CT as I wish. However, if I do a PET MRI, here's a PET scan, the MRI scan of the neck, and you see all this detailed muscle, cerebral spinal fluid, and this gray stuff is a lymph node. PET CT in the same plane, you know, you'd be hard pressed necessarily to prove where it is, but when you combine the two things, you see, that's a lymph node. It has other friends round about heading down the neck. This bright spot here corresponds to this gray spot that does not belong in the cervical spine. This tissue back here, which wasn't too different in color than that tissue, is actually just normal mucosa, and then some glands that are normal as well. So by using this technique, it's possible to combine the exquisite soft tissue contrast of the MRI with the physiologic information of the PET. So I think the next steps are really going to be problem solving, combining physiology and tissue characteristic, and doing what's called TNM staging with this tumor, nodes, and metastases better. And if we have radiopharmaceuticals which have a high specific binding to a tumor, in other words, all you see is this one tissue in the middle of an empty space on a PET scan, you absolutely have to have an anatomic image at the same time. So that'll allow things to take place more rapidly. So the hope is that new radiopharmaceuticals can be evaluated for human use more rapidly by the fusion of the anatomic and physiologic data. And theranosis is really growing. New molecules are developing as both imaging agents. So you have a molecule, tag for imaging, same molecule, tag for therapy, and those I think are really going to be the future. On the other hand, I'm probably wrong, and I drew the wrong bird. So hopefully what I said was reasonably understood, and you'll be able to tell me later if I was even close to being right. Bird's probably red. Anyway, thank you for your attention, and I appreciate the opportunity to have spoken, and I guess now we have still time for questions.
What is making you decide that a patient needs further testing? Is there a blood test that finds the cancer first? What is the first step before they go on to this dramatic?
That's a huge problem, because we really would like to have decent blood testing. There's measurements for ovarian cancer that are not specific enough and would scare people too often. Colon cancer blood test, same. So unfortunately, it's symptoms and screening. So prostate cancer screening is going by the wayside, but not colonoscopy. Not routine chest x-rays when you're in a high-risk category. So unfortunately, it's vigilance about yourself and screening, which is how you come to attention. But there are some blood tests that are being developed that we hope will pick up cancer cells when they're small. But really, it comes down to vigilance and screening.
Within the academy, is your work considered controversial? In other words, you started out by talking about the so-called anxiety. You dropped the word nuclear from things because there's anxiety producing. And so, in other words, I don't quite get the feeling that everybody, from what you're saying, that everybody's on board, and I'm just asking you.
No, that's a very interesting question, because dropping the word nuclear out of nuclear magnetic resonance imaging, we all thought was overkill, and most of us are still calling ourselves nuclear medicine because we are using the atom. So the anxiety is actually declining with education, and also we are ourselves recognizing that we need to treat patients with the lowest possible dose. But I think the risk is still very overstated, and we're addressing this fear not because I think you should be, but because the phobia is there. And that's really the reason people are dropping the word nuclear or changing themselves to the Department of Molecular Imaging and Biochemistry or something like that. But I think it's overdone, and I think as new data comes out, the hypothesis is called hormeosis, if I remember right, where low-dose radiation is beneficial, and that has been proved actually by hundreds of studies. So we're getting there, but yeah, so I don't think it's controversial that we're doing it. What's controversial is the worry that people have, I think, and how to measure it. Again, we lack standards.
The The Origins Science Scholars Lectures are presented by Case Western Reserve University's Institute for the Science of Origins, with the assistance of the Siegel Lifelong Learning Program, the College of Arts and Sciences, and MediaVision. For more information on the Origins Science Scholars Program, including a full video archive, please visit the Institute's website at origins.case.edu.